Okay, that's always very difficult to start when it's just the coffee break, and but sure, a lot of people we are entering here. This is the third day of the meeting. This is the last run, and this morning we have a very nice and pleased session regarding the embolization treatment for all what is bleeding, and this is an increasing part in our current practice. And what I love with this session, this is purely a multidisciplinary session, and I'm learning so much from all the other specialties. This is really nice. And I'm very pleased to animate this session with two brilliant guys, Narayan from the UK, and Jose Ignacio. I never know what is the surname in all these names.
I have so many names, like the rich people.
Nacho.
A lot of
We
names.
call you Nacho.
Nacho, that's fine. Yeah.
Nacho, that doesn't appear in the name, but anyway. For this session, please, maybe Narayan, you may ask for the first speaker.
Yeah, thank you so much. It's an absolute pleasure to introduce Dr. Virender Singh Bedi from New Delhi, India, for the first talk on embolization in orthopedic disorders. Welcome, Doctor.
Thank you.
That is an increasing part for the treatment of people.
Yeah, thank you. I think when this topic was offered to me, I was in a bit of a dilemma as to what I need to work on. And then, of course, I decided to talk about problems of musculoskeletal disorders. So this is what I'm going to focus on. I have no disclosures. And when you look at the objectives for these kind of patients and all, to understand the pathophysiology of musculoskeletal pain and neovascularity, transarterial embolization, the principles, techniques, and the embolic agents which are there. Review evidence from recent clinical trials, because this is a very, very new topic which has come up, and explore the clinical applications, of course, in Indian practice also, as well as discuss the outcome, complications, and patient selection. So when you look at the evolution of transarterial embolization in musculoskeletal pain, the first study came from 2013 from Okuno, by Okuno et al. He used imipenem and elasticin for tendinopathy, and then after that 2015 to 17 genicular artery embolization. And then recently you have the 24-25 randomized controlled trials emerging from Van Zedelhoop study. So I think this is a very, very new topic, I would say, in terms of management and all. But it's a very interesting topic, because at the same time, when you look at the rationale for treatment for transarterial embolization, the problem is a chronic pain refractory to conservative treatment, and this is something we see very commonly in our older subset of patients. To look at the pathophysiology and the solution, which is selective embolizations of abnormal vessels. When you see the role of neovascularity, there's a chronic inflammation causing abnormal angiogenesis, neovascularity associated with increased nerve growth. Then you have this hypervascular zones which demonstrate substance P, CGRP activity, and the vascular endothelial growth factors. So all these things, the purpose is to treat these by reducing the inflammation and reduction of inflammation and pain relief. And so the clinical applications today, which are established, is for treating knee osteoarthritis, shoulder adhesive capsulitis, and rotator cuff tendinopathy. There's growing evidence of using it for plantar fasciitis, patellar tendinopathy, lateral epicondylitis. Again, emerging also the similar Achilles tendinopathy and tibialis posterior tendinopathy. So I think very, very interesting. And now this is what we need to see when you look at the anatomy of the lower limbs. You look at all the genicular arteries which are there, the superior, inferior, and all of the branches out there. And then again in the plantar fascia, you look at the posterior tibial artery. So when you decide which patients and all to choose for this one, the inclusion is from 18 years to 80 years in refractory musculoskeletal pain. Exclusion, of course, in acute infection, severe PAOD, coagulopathy, and all these other conditions which are there. And the most important part is a failure of conservative treatment with other drugs and all. If it is more than 3 months period, then probably you can consider these patients for a treatment out here. As a part of the pre-procedural workup, you would like to get an ultrasound done, or a CT angio, or MR angio, or a conventional DSA to look at the blush out there, and then decide the appropriate treatment for that particular patient. To look at the embolic agents, you look at the temporary embolic agent, embolization agents, gelatin foam, gelatin microspheres, or imipenem or cilastatin, or even the permanent ones, which is basically injecting alcohol or embosine microspheres. And then, of course, you have the permanent, like the glue, the onyx, and the ethanol. When you look at the embolic agents, the properties are, again, imipenem, cilastatin is non-FDA approved, off-label. Gelatin, of course, it resolves in about 2 to 6 weeks, and the PVI particles, they have a much durable effect out there. So the treatment is, the results are just the same practically with both, either short or long term. Of course, with an ipsilateral or contralateral puncture, you go with a 5 French sheath out there. Then you go across, you place a 4 French GR catheter, selective cannulation of the target artery. And I'll just show you a small video of a case which is done. And the main thing is to use a small quantity of iodinated contrast, and then after that, identify the blush. And then incremental boluses out here. And then after that, basically, just to show you this video, we've gone from the contralateral side in this particular side, and then we go across down below, and then we try to look for the target artery out here, which you can see on top. We will just try to get across a catheter, a microcatheter inside that. With the catheter just manipulating and trying to get across into the selected vessel, and once we are there, we see the blush out there. And again, now we move down with the microcatheter down below. And you can see the blush lower down towards the condyle. And then with the microcatheter, we inject 150 to 200 microns PVA particles out here. And post-embolization, you see that the blush disappears completely after that. So again, same kind of technique is followed in shoulder transarterial embolization, which is basically adhesive capsulitis protocol. Same kind of thing for plantar fasciitis. You go across into the posterior tibial artery and then go across, look at the hypovascular brush at the calcaneum attachment of plantar fascia, and then inject either imipenem, cilastatin, or one of the gelatin spheres. And resolution of the facial blush, of course, is the one thing which is there. And then, of course, the standard compression out there. So when you look at the Indian clinical experience in terms of knee osteoarthritis, basically a study by Gandhi et al. Showed early outcomes from Indian center performing transarterial embolization, and they had a very good result out there with significant pain reduction across the cohort during durable relief for more than 24 months out here. And again, another patient from data from plantar fasciitis also showed a similar thing. And when you look at this systematic review outcomes, 64% they had a pain reduction out there at 6 months, visual analog scale, 80% at 24 months, and 78% patient met the threshold out there. Again, similar kind of results even with tendinopathy also, again, very good results. And I think this is the most important part out here, the durability and the retreatment rates at 2 years. 5.2% underwent TKR at 24 months, and only 8.3 required repeat genicular artery embolization at 24 months, and 86.5% patients maintained single procedure benefit out there. So again, these benefits which are there, you need to look out for some complications like skin changes, paresthesia and all, which by and large they are reversible. And to look at the future directions out here, complex musculoskeletal conditions, rheumatoid synovitis, psoriatic arthropathy, embolization, along with sports injuries, again coming up in a big way in terms of athletic injuries with chronic neovascularity. A hybrid approach will very well help in treating such patients and all, and identifying the biomarkers which are there, and probably long-term studies for 5 to 10 years to look at the data which is there. And to conclude, it's a safe and effective for refractive musculoskeletal pain with neovascularity. 60 to 80% pain reduction maintained up to 24 months plus, and low retreatment rates suggest a true disease modification. Temporary and permanent embolic agents yield comparable results and require super selective techniques to minimize complication. And of course, choosing the right patient is very, very important. Thank you very much for your attention.
Thank you so much. Naraya, you want to comment?
Yeah, no, thank you so much. It's a great overview of where we're at, and it's clearly a expanding field with better understanding of the techniques, indications for use. Are there any questions from the audience? Yeah.
PK?
How are you, Dr. Bedi? Great presentation. Just a question. Is there any role for coil embolization? Because we're hearing that a lot more in the States. I'm not sure if there's any role.
See, I think these vessels are very, very small vessels and all. So probably the coils are not that effective in terms of targeting that specific area, because you really need to go very, very selective and go into the blush. So unfortunately, the coils might not work very well in those conditions.
Yeah, the question I was going to start with is, in terms of the patient selection, obviously degenerative disease, osteoarthritis is a spectrum, and you have the sort of the early changes and the sort of middle and the sort of advanced stages. Where, which patients would be the ideal candidates to do genicular artery embolization in that group?
Yeah, so I think a lot of patients who have severe osteoarthritic pain, like I mentioned, that refractory treatment, you give them a lot of analgesics. There are a lot of people who keep on popping up pills every day because of the knee pain. A lot of those patients don't want to get even surgery done for a joint replacement and all. They don't want to get it done. They have severe osteoarthritis. I think these are the patients who will probably merit a procedure out here in this one.
That's interesting. I'm going to challenge you, if I may, and ask the question, which I guess might be the elephant in the room, which is, if you have a patient whom down the road you may do a knee replacement for, and you're cutting off the blood supply to the femoral condyle, which you kind of need for healing of the replacement.
Yeah.
Is there any long-term consequence of doing genicular artery embolization should that patient proceed?
I think great question. I think again, see the knee area generally that has got a very good vascularity out there. So just knocking off one small branch, which is especially targeted towards only that particular area, should not really cause much of a problem, because you're leaving the main genicular arteries. You're not really touching them at all. You're just basically going selectively and going across into that small vessel, which is causing that kind of a blush or neovascularity which you're seeing out there. Yeah.
I think there is one question. No, there is no question here. I'm very impressed, and I think this is already the future, but this is
it looks like
the next booming futures. And when I will have some knee disorder, I think this is the same for the prostatic problem for male.
Yeah.
I would like to be embolized and not to be surgically treated.
I think the evidence right now, the initial evidence is showing that it is going, it has great results and also.
And there is so much to demonstrate, to explore. This is just fascinating. And what's fascinating me, that's a part of my PhD, that was to create neovascularization for ischemic patients. And now we close the inflammatory neovascularization. That's
true.
And I've got one remark and one question. Maybe in some young, in bracket patient, create some orthopedic fragility, or it's just treating the extra vascularization?
I think you need to assess the patient in totality and see, basically. Many a times, a lot of patients have severe osteoporosis, for that matter. So you need to see that the pain is basically because of this particular problem and because of neovascularity and not because of something else. So in which case the patient is going to be cursing you for a lifetime after that.
And my question was, that was a left knee, a right knee, on the example of
it was
one not coming directly through direct SFA.
Exactly, yeah. So I think that's what I said initially, that you can go antegrade, you can go retrograde, whatever you feel comfortable with. This was done by one of my colleagues, but it's just a matter of protocol.
This is amazing, and thank you for coming from India for us. You want to introduce the next speaker?
Absolutely. Absolutely, it's our friend.
He can't introduce himself.
Yeah, you can introduce yourself. But anyway, thank you for your presentation.
Thank you very much.
And our next speaker, our co-animator, is Narayan Karunanidhi. I don't know if I did well.
Very good.
Narayan.
Thank you, from the UK. And he's going to talk about trauma bleeding, examples, and treatment with pragmatism. We are willing to listen to you.
Great. Thank you so much for the introduction, and thank you again for the invitation to be part of this excellent, amazing conference. And so really in the next course of the next 6 to 10 minutes, I'm just going to talk through 3 case examples of trauma embolization, just to illustrate the, what we believe is the sort of the basic fundamentals. And of course, this is very much an interactive session. Please feel free to critique the cases and the management as you see appropriate. These are my disclosures. And so really, when we consider trauma embolization, there are fundamental steps beyond just the procedure that you just need to get right, and that just ensures that the procedure is done safely with the best possible outcomes. And fundamental, of course, in that sort of trauma setting is the pre-procedure optimization of the patients, because these patients often, if they're major trauma, either soft tissue or bone injuries, will potentially have a large bleeding risk and complications. So that sort of pre-procedure optimization according to the ATLS guidelines is something that's fundamentally key here. You obviously need to have excellent pre-procedure imaging to really understand the pathology you're dealing with, the extent of the disease, the extent of the vascular injuries. And then when it comes to the procedure, the clear considerations are, where are you going to do the access? Sometimes if they have pelvic trauma, you may be faced with a situation where you're dealing with pelvic binders. So that's obviously something to consider. There's clearly, the sort of once you get going, the speed of the procedure is key. And so you do need to be familiar with the tools that you're going to use to treat. And clearly, as with any intervention, any surgery, having a bailout strategy is also key. So on to the first case here. This was a 30-year-old patient who had a trauma injury where she came off a bicycle on a busy London road, complained of pain in her abdomen, and this was the coronal reformatted CT scans. I don't know if there's anyone who'd like to comment on it, but essentially this patient, sorry. And try to play that. Yeah, here you go. So this patient had hemiperitoneum. You can see the blood around the liver. There's blood in the pelvis, so there's free blood within the peritoneum. The patient was shocked. And as you see here up in the left upper quadrant, you can see a high-grade splenic laceration, which was the cause of the hemiperitoneum. So in this patient, we wanted to treat this with embolization. We've accessed the common femoral artery using a catheter and a microcatheter system. We've got selectively into the splenic artery. And you can see on this fluoro sequence, you can see the site of the pseudoaneurysm here coming off the splenic artery selective branch. And obviously with modern techniques, you can get very selectively into that and selectively coil embolize the bleeding vessel, preserving the rest of the flow to the rest of the spleen. This patient had a very good clinical outcome with a restoration of the hemodynamic parameters and made a good recovery from it. We didn't do anything about the hemiperitoneum.
Narayan, can I ask you a quick question? Sure. In this scenario, would you consider any other embolic agent?
Yeah, I think that's a great question. I think this was what we used in this particular case, but I throw it out to you. I think I don't think there's any one way of doing it. I think there are many other embolic agents. There's the mechanical agents like coils. There are liquid agents like glue, and there are other agents like particles that can be also used. What would your choice of agent?
Probably glue.
Yeah.
Probably glue.
Yeah, great. Anybody else? Any other takers? What would you use? Coils. Yeah. Okay. Yeah. Yeah, I think So I think it's right. I don't think we can say one is right and one is wrong. I think there are many different ways. But the key thing is whatever you are familiar with using, use that, because this is not the time to go, I want to use the first coil that I've ever used in my whole life in this sort of scenario. This is not the situation to do that. And I think that's the key message here, I think. All right, okay, so second case. So this is a patient who, again, had traumatic injury. She was actually postpartum as well. As we see here, she had a large anterior abdominal wall hematoma on the CT scan. This is between an arterial and a venous phase, but you can clearly see an extravasating vessel going into that hematoma there.
This is purely muscular, yes? In
yeah.
the anterior muscles. Well.
Correct, exactly right. So I think the key features on the CT scan was there's no hemoperitoneum in this instance. This is all contained hematoma within the anterior abdominal wall. However, this was causing hemodynamic collapse, drop in hemoglobin down to 40, and so therefore, felt required with this evidence of active extravasation to proceed to treatment.
Is there any mesenteric damage or no?
No, not in this situation. I've only got a selective CT scan, but obviously the patient had a full CT scan, and that didn't show any solid.
My point of view, is it really necessary to treat it?
Yeah, I mean, the hemoglobin was down to 40.
This is my first. Huh?
Yeah, so therefore.
Feature.
Yeah, but I think that's a good point, because I think sometimes. I think, seeing that active extravasating vessel and a drop in hemoglobin down to 40.
We say is very painful, very unstable, it's needed to treat it.
Yeah. So we proceeded to treatment. In this instance, what we've done is we've come from a up and over approach because we felt that the bleeding vessel here was a deep inferior epigastric artery.
Again, why the crossover? Because to go directly to the epigastric, once again, we may have puncture directly or the CFA or just below the first part of the SFA. That could have been also a good option, no?
Sure. Yeah, I don't disagree with that. Deep inferior epigastric arteries, I quite like the crossover because I just like to hook it back into it. I think it's a more stable position. If you come ipsilateral, then your sheath is then half in, half out, and it can be a little bit, But this is a really easy technique where you have a crossover sheath, you have a reverse curve catheter, and I've cannulated the deep inferior epigastric artery. And as you can see here, you can see the two areas of blush here, one there. And one here, which is the sites of the extravasation leading to the bleed. So what we did was we then cannulated the, okay, I'm going to pause here actually and ask you, okay, so what would you do here? Would you go glue here too?
I like glue. Yeah, we have experience with glue. And with that kind of small vessels, distal bleeding, I think we would go for glue.
Okay. Yeah. Anybody else?
I would do exactly this.
Okay, great. Thank you.
I'm used to glue, so I'm
yeah.
coil guy.
Okay, I'm gonna try.
Anybody disagree? Another option? You open?
So what we did here was, I think this is a key part of one of the key important principles in embolization as well. When you, especially dealing with a vessel like the deep inferior epigastric artery, and that's not the only vessel, there are other vessels out there too, where you can get sort of, if you close just the front door or the inflow into the vessel, you're only dealing with half the problem, because you can then get reverse flow coming from the inferior internal mammary artery down the superior epigastric artery, and you can continue having the flow into the vessel. So what I did here was get past the the vessel going to where the extravasation was, and coiled that outflow, as you can see here with that coil. And then to keep my colleague and co-animator happy, I glued this. I used glue brand 2 mixed with lipiodol, and this is me slowly injecting the glue as I'm then pulling the microcatheter back. And so this is a really good, fast, cheap way of embolizing this sort of situation where you have branch vessels, and you can see that sort of glue cast forming in where those pseudoaneurysms or areas of extravasation was, and you can also see that glue cast forming in the vessel as it comes down into the feeding deep inferior epigastric artery, and this is a glue cast that's left behind. And so you can be very confident and that you've completely embolized it. And just one final case in the last minute or so, not every case of trauma requires an embolization. This is clearly a traumatic injury of the subclavian artery, and you can see the extravasation as well as the fistula formation between the subclavian artery and the internal jugular vein. And as you inject contrast, you can see the sort of the communication with the vein as well. And in this case, a straightforward covered stent across it is adequate at dealing with the situation and resulting in a good clinical outcome. All right, okay, so in conclusion, as with everything we do, by failing to prepare, you're preparing to fail, and that couldn't be more true of trauma embolization. You've got to be clearly familiar with the tools and the techniques, and as we discussed in the cases here, there's not one way of doing it, there are many ways of doing it, but also having a clear bailout strategy is key going into these cases. Thank you very much.
Thank you so much.
Thank you. Any questions from the audience?
Oh, sorry. There's just a light here.
Thank you for excellent presentation. I would like to ask, do you routinely use gel foam for trauma embolization?
Yeah, there are certain instances where gel foam is something that I would use. Postpartum hemorrhage is one of those situations, and sometimes when you have extensive pelvic bleeds and it's just coming from multiple sources, and I'm not able to get very selectively into that one bleeding point, and I want to, for example, embolize the whole anterior division of the internal iliac artery. In those instances, I'd be very comfortable, and I do use gel foam, and I think it's a very good agent in those situations. Where possible, with the worst outcome for me is do an embolization, the patient leaves, and then they have to come back 6 hours later because they're rebleeding. So, as much as possible, if I see a point of extravasation, I want to close that and be confident I've permanently closed it.
Narayan, great presentation. Just a question, as a cardiologist, we don't use glue a lot or gel foam for these kind of things. Coils we're very familiar with. What are the potential complications with this, when we use it, and what are the products available to use?
Yeah, great question. I think there's a difference in availability in the US and in Europe. So the older versions of glue, which was the histoacryl, polymerized really quickly and in an unreliable manner. The newer agents, which is glue brand 2, has a it's very straightforward sort of polymerization time and gives a really good sort of, flow beyond it. So I think, and there's ways of sort of making it more viscous or less viscous and mixing it with Lipiodol. So Glue Brand 2 is our agent of choice for this, and it works really well. Of course, with any embolization, you've got to watch out for non-target embolization, which I think can be managed quite well. So glue is a very good agent to use, but I think it's complementary to coils and plugs, because I think there are, definitely situations where I would use that too. Would you agree with that?
Absolutely agree, and it's something you need to be familiar with, and it's, I think it needs some kind of learning curve when you start using it. Yeah. Any other comments? We have another comment over here.
Thank you for the presentation. Just for a question regarding the splenic artery embolization. For such a severe parenchymal injury, do you do proximal embolization in addition to your selective embolization?
Yeah, I think that's a great question. I think here we were quite clearly seeing where the extravasation point was, and therefore I didn't see a reason to take out the whole splenic artery. There are instances when you may, where you're unable to get so selectively, but I think if you're fairly confident you're seeing, the extravasation point, I think the general rule is try to be as selective as possible, and we were able to do that.
But was the patient stable or unstable at that point in time?
Yeah, that's a great question. So the question was how stable or unstable. And I think this patient was relatively stable at that time. There have been times when, especially when you have a big hemopericardium, you can almost develop a compartment syndrome because they've got so much hematoma and pressure. And then getting so selectively or super selectively can be technically challenging and, importantly, time consuming. And what you want to do there is minimize the time by trying to get in and out. So in those instances, I completely agree with you. I think you should, get what you're given and embolize as distally as possible. But if it's a whole splenic artery, that so be it.
What we may do when it's very big vessel, big in brackets, like a renal artery or things like that, or iliac with some branches, we do a large sheath, and we do two things. We are endoclamping with balloon the trunk, the proximal trunk, and in parallel we do that. We deal with our radiologists also, and in parallel we have the catheters that is around in parallel in the wall, and the balloon. That's the trunk is endoclamp, and after we are selecting, we preview on the first angio, and we know approximately where we need to go on, and we may do some selective, but when the patient's quite unstable, this is endoclamp before. That could be quite tricky.
That's a great question. That's a great comment.
I asked the question because I had some cases where I did this the same way, selectively, and then the patient got more stable, so the blood pressure rises, and then get another bleeding, and you have to come back in the night. That's I got a
Yes. Yes.
There's another question there.
I'm ready.
Thank you for this great session. My question is in pelvic fracture trauma and unstable patients and without a clear bleeding point, maybe venous. Do you embolize both internal iliac arteries, and what do you use? Thank you.
Yeah, I think that's a great question. I think, obviously, you want to be certain you're dealing with an arterial bleed rather than a venous bleed, because if it's a venous bleed, I don't really see a role for transarterial embolization. So I think if your CT scan demonstrates sort of arterial extravasation and you're unable to be, lateralize it, I think that's an unusual instance. Usually if you see a pelvic fracture, it's usually the vessels next to the pelvic fracture, and often the presacral plexus, which is often, the ones that you need to treat. I think you just need to just go in and be as selective as possible. But if you have to take out the whole anterior division or the posterior division, I think that's okay. I probably wouldn't do bilateral, and I probably use, this is this instance when I would definitely use gel foam as a temporary agent rather than like a permanent agent like glue in those instances.
Okay.
Absolutely.
We need to move on.
Move forward. So next speaker will be our friend Prakash Krishnan from New York. We are continuing talking about bleeding.
Bleeding.
Scary bleeding
Yes.
during procedures.
But you have to treat it with calm.
Well, I'm getting in a feeling that Eric definitely wants me to show all my complications. So this is a great case, and I think this topic is very important, bleeding during procedure, example, and treatment with calm. So this is a sudden thing that can happen to all of us as we're in the lab and we're working. It's a 79-year-old male with severe aortic stenosis of the bioprosthetic AVR. He had symptoms of chest discomfort and exertional shortness of breath. Class 3, he was sent to Sinai for TAVR evaluation. Obviously, he has CAD. You can see his other comorbidities, and he was adequately medically managed. So again, you can see he was severe AS with an EF of 30%. He had RV dysfunction, pulmonary hypertension, and he had high risk scores that clearly made him a candidate for a percutaneous approach. So it was decided after CT scan was done, evaluation was done of the arterial vessels to proceed with a TAVR. So when they went up, what happened was they did a balloon valvuloplasty to go ahead and prepare the valve to receive the TAVR valve. And then what happened was as they were pulling back the balloon, they lost the wire. Actually, they pulled the balloon back and they introduced the valve. And as they were advancing the valve, because of the iliac tortuosity or tightness, I'm assuming I wasn't there, they lose the wire. So when they lose the wire, they have the valve, and they had to pull the valve out of the body to rewire into the LV, which is a difficult thing to do with the valve there. As they were pulling the valve out, this is what they got. They had they pulled something out. There was a lot of difficulty in the iliac, and then this is kind of what happened. So then at this stage, we were called in. So we were called in. Now the patient, to make it even more complex, had developed a high regurgitant fraction, meaning that the balloon valvuloplasty of even the bioprosthetic valve ruptured the valves and resulted in a very severe AR. Regurgitant fraction was around 48, moderate to severe, didn't quite meet severity. 50 is severe, but 48 was pretty close. And in this situation, he became very, very unstable. So at this situation, I don't know, what would you guys do? This is a difficult situation. You have a balloon, you have a guy who's crashing on the table with a bioprosthetic valve. So what we decided to do was we needed to temporize the bleeding and at least get this under control, and we had to deal with the valve. So we decided to advance a 22 French sheath across the iliac. So when we put a 22 French sheath across the iliac, it stabilized the bleeding, and the hemodynamics were not great, but at least he had a blood pressure of around 70 or 80 as compared to 40 systolic. So at this stage, we had a little bit of a group discussion, and we said, okay, let's go ahead and fix the aortic valve first, because otherwise we're never going to be able to stabilize the patient. So our team went ahead, and you can see... Yes, sir.
With the quality of images and your hand under the fluoroscopy, we say with calm.
That was my fellow's hand, Eric. So we went ahead and fixed the valve, and you can see here we put another valve in valve. You have echo, and obviously the patient has pacemaker and other stuff. So after the valve was fixed, at this stage, okay, we were now stable. The AI was gone. As you can see, there's no demonstrable AI. And then we went ahead and said, well, now this is where we're at. What are we going to do? So any thoughts? Yes. Okay, so the problem with that, sir, was that we didn't know where the rupture was. We weren't certain whether it was a level of the internal-external, a common bifurcation, or was it at the level of the common femoral. So at this stage, we decided to go ahead and put an aortic occlusion balloon.
This is never at the CFA. This is always the junction between the external and the CFA. And sometimes when you're pushing, I've seen it sometimes, This is between the common and the external iliac artery that may happen, but it's very, very rare. The most common when you are entering and pushing too much, this is always the connection between the external and the CFA.
But in this case, Eric, it was when they were pulling the valve out.
Yeah.
So I'm assuming it could be either or, and we weren't sure.
That's right.
So what we did here was we went up, and obviously we didn't save all the images. We took a picture with the aortic occlusion balloon to, again, minimize the bleeding. And I think this is a very important step, and I'll go over. And then we tracked a balloon, a catheter down, and pulled back and injected, and identified 2 areas of rupture, one at the level of the internal, external, like Dr. Dukas said, and the other one at the CFA. And you can see here's the one at the CFA. You can see the bleeding off to the side, and that's the area where we're assuming that there was no flow, obviously, because we were occluded. And so at this stage, we decided to take a 13 French sheath up and over, and then we decided we put a Viabond, 13 millimeter Viabond across the common into the external, and then I believe I'll show you later, a 10 millimeter Viabond down into the CFA. So we called our surgical colleagues always, anytime, and I'll go over that, and our surgical colleagues were there. So at that stage, we decided to externalize the end of the Viabond and then suture it to the common femoral, which, as you can see by the surgical clamps, were there. So then at this stage, we balloon occluded, injected while they were doing from below, and then with a final picture, we were able to stabilize the patient with obviously loss of the internal iliac, but unfortunately, there was nothing we can do at this stage. So now we were able to stabilize the patient, and I think the patient post-op, obviously he got his valve, BAV was performed, again, the valve was unsuccessful, and then on recapturing the CFA and internal common perforation, and then TAVR completed with access injury, dealt with a Viabond 13 by 100 from the common. And again, it was nice because we had the measurements from the CT going back to the preparation, and then an 8 by 100. It seems very large, but we wanted to have a lot of overlap to be able to control and not have any endoleaks at any time. He recovered well. He had 3 units of PRBC. He, of course, with all this going on and shock, he worsened his CKD, which improved back to baseline, discharged home after 10 days, and has been seen and has been doing very, very well. So, I mean, what are the things that we learned? And I think what are the things that we all should remember? I think the first thing is you need to stay calm, as Eric's topic said. And the second is you need to control. So if any sort of perforation, you need to have a large bore sheath in order to control the aorta. And I think that's very, very important. And also think about using the sheath to prevent the bleeding, because sometimes your sheath may be enough to be able to create a seal from the proximal normal segment across the bleeding segment and then be able to prevent this. Again, when you use a aortic occlusion balloon, always use a balloon to cover the rupture, but sometimes you're not sure where the rupture is here. So ballooning the aorta with a low pressure balloon may prevent from having any extravasation and give you time, if you're not a surgeon, to call your surgical colleagues and get the team together. So that's very important. Call for help. And I think hypotension is okay as long as it's permissive, meaning there's not a sudden crash in blood pressure and a sustained crash in blood pressure. You are going to bleed, you have to accept that, you know. And then it's important now to make sure you have other IV accesses. Obviously, this was a TAVR case, but if you don't have a large bore IV accesses, make sure your colleague is getting other bore IV accesses. And again, always activate a surgeon if you're not a surgeon. And then the final principle is plug the hole. And you have to decide, is there an adequate seal zone above and below? So do not worry about the scaffold being way too long, or I'm sorry, I keep saying scaffold from yesterday's talk, the covered stent being way too long. And then because if you have an insufficient seal zone, now you're going to be chasing where you're bleeding, is it proximally or distally? So it's very important to make sure you land proximally and you have this. And of course, if you need to deal with aorta, having the surgeons there will help you if you're not very facile with other aortic equipment. And the other thing is, if you're doing any sort of complex iliac work, aortic work, SFA work, it doesn't matter what. You know, perforations are going to be part of the deal, and they're going to be part of your procedure. Not every procedure needs to be sealed with a covered stent. You saw a wonderful talk on coils, which we frequently use for side branch perforations inadvertent while getting through an SFA or a difficult tibial vessel. So that's also important. And again, the equipment that you have in your room is mandatory. Any sort of complex lesions needs to have wonderful preparing, as Narayan said. If you're not prepared, you're going to be caught with your pants down, and the problem is the patient is probably going to be the one to pay the price. So now also, never accept just balloon angioplasty and leaving it, because you never know. As was stated earlier, this could open up later on at night. Right there, you have a ability to seal it completely and then finish the case on the table. So when you know that if it's a small SFA side branch perf that looks good, you may want to leave that. But if it's an intra-abdominal bleeding and it looks good with the balloon, you may not want to leave that, because that may open up down the road. So again, after that is remember also to follow up, because now you've reversed anticoagulation. You don't know what the runoff was, unless in this case we had a CT. If you don't, make sure you do runs below the knee. If you're dealing with any sort of perforation, that you balloon tamponade it and reverse anticoagulation. Because what happens is you may form distal clots, and distal clots may be an issue. And last but not least, angiography is good and probably at that time the best thing, but don't hesitate to get a post-op CT scan to ensure that you've done the job that you have. Because sometimes you may have retrograde leaks that were shown. You know, maybe there's a branch that's been severed that's leaking slowly from the retrograde. So that's very important. But obviously you have to weigh that very carefully based on contrast load and your index of suspicion. But we generally always follow up with a CT scan. And I thank you. I hope that was useful. Thank you.
Thank you so much. We have short time for question and discussion.
Questions? I think you mentioned about self-expandable cover stents as first option, but balloon expandable cover stents is an option too.
Absolutely. Okay. Yeah, I think that's a great point. If you don't have the right sizes of your Viabond, we had a 13, we're a very busy center, so we had all that. But sometimes you may not. You may have a VBX or a balloon expandable. May not be the ideal spot, but to save the patient, you have to do what you have to do.
The question I have is, I mean, it's a great presentation. Thank you so much for being so candid and sharing such great learning experiences. So obviously you had a situation where you had clear extravasation from the iliacs, but you obviously had a situation where the aortic valve was leaking as well, and so you opted to put a large sheath in to sort of maintain temporary access. So my questions are, what was your rationale for not dealing with the iliac to start with, and then once you got control, then dealing with the aortic valve? And the second part of the question is, when you put a large sheath like that, are you concerned about distal perfusion to the limb?
I think that's a great question, and these are things that we didn't even think about. The bottom line, I think, was we didn't lose the wire. If we lost the wire, I think it would have been soup. We would have been in a lot of trouble. And I think in that panic for the audience, you just make sure you don't lose the wire. The second idea was when we put the treating the valve here, we were forced to, because of the severe AI and the hemodynamic collapse. Regurgitation acutely of 50%, the LV, especially with the EF of 30%, can't handle it. So that was the number two. And number three, we were able to seal it. So once we were able to seal it and the hemodynamics stabilized, we said, we made a group decision, and with our vascular surgery colleagues who felt comfortable to fix the valve because they weren't comfortable, God forbid he bled out, then he'd definitely pass.
Thank you so much. We need to move on.
Thank you, sir.
Who wants to announce the next one? This is almost a Dutch session into that session, because we have 3 Dutch guys. One is exiled in Switzerland, but anyway, it's Dutch. Please, Natasha?
Yes, so we have now our dear friend Arjen Hogsbergen from Amsterdam talking about new polymer filling for type 2 endoleak.
Thank you, audience. Thank you, Eric Ducasse. And I realize this is a session about bleeding. Now we're going to discuss a different type of bleeding, persistent bleeding in the aortic sac. And the disclaimer is that one of my very high esteemed colleagues, Professor Jan Blankenstein, does not believe in this concept at all. So this is a disclaimer, and it's not only about the polymer, it's about all the things you guys probably stick into this aneurysm to stop these type 2 endoleaks. So this is a short disclaimer. It also is known probably that the type 2 endoleak is a misnomer. It's just period graft flow. But we all have these patients on our outpatient clinical ward that come back, and the aneurysm is growing every year again. It's 8 centimeters, and it's 9 centimeters, and it's 10 centimeters. Then they develop some pain in the abdomen, and when you look at the CT scan, it's just a type 2. So what we're going to do, then I ask Jan, what is your suggestion? I said, just follow them up. But to what diameter is it? I don't know. So to outline the problem, these are my disclosures. Type 2 endoleaks, we all know that treating them is is difficult. And probably Jos van den Berg will say, this is not true, I have better treatment. But when you look in the literature, the technical success of transarterial embolization and the technical success of translumbar embolization is really high. But we all know that the clinical success is coming down over time. So we need maybe another type of solution than the typical materials we commonly use, like onyx glue or coils. This was the reason for the company TripleMed to develop Anifix. Anifix is a 2-component injectable polymer which is specifically designed to fill the nidus in type 2 endoleaks. And it's injected through a translumbar puncture. This is the system. It consists of a gun called dispenser. It has a double-barrel syringe containing the Anifix polymer. It has a static mixer, a tubing, and the needle through which the polymer is injected translumbar into the endoleak. This is how the material looks like. It has a relatively low viscosity, and when it comes through the mixer, it looks like a kind of toothpaste. And when you inject it into the endoleak nidus, it forms a solid elastic implant with a cure time of about 3 minutes.
This is very impressive. Not very sexy. This very impressive.
What do you mean with sexy?
Of course, this bleeding is a nightmare.
I agree. We started the Anifix Type 2 endoleak trial. This is an international prospective multi-center feasibility and safety trial, and we now have, it's ongoing, we now included 53 of a total of 57 patients. We only included patients with significant growth, so more than 10 millimeter according to European guidelines. We excluded in the first phase patients with an open inferior mesenteric artery connected to the endoleak, just not the push or lock.
Sorry, but this is the concept of the PVI, to be interrupted. So why excluded the IMA involved in endoleak?
Because we were not sure.
My feeling, I'm not certain, but my feeling that's always coming through the lumbar, and the exit is always through the IMA. Just I think that IMA it's almost all implicated in all the type 2 endoleak, no?
It's
maybe I'm wrong.
It's an extremely good point for discussion. What is the inflow? What is the outflow? We always try to, when we do the sac angio, to see which is coming in, which is going out. It's really difficult to say.
I think it's based on the, I won't say experience, but when you are coiling the nidus, that is almost always the lumbar. And when you see it on the follow-up, you see on the angio-CT that's all the coils are growing up into the sac of the aneurysm and following the direction of the anterior part of the sac. That's we imagine, or we are quite convinced that it's coming through the lumbar and exiting through the IMA.
Yeah. And I think most physicians will treat patients with a large type 2 endoleak with a huge IMA by coiling first.
Okay.
And then go further if it doesn't work.
Makes sense.
And usually it doesn't work. Okay, the primary endpoint was successful puncture and filling of the endoleak with this new material, and secondary endpoints were absence of sac growth at 6-12 months. This is how we do the procedure. We do these procedures on the hybrid OR. We start with a cone beam CT. The patient is in a supine position under general anesthesia. Next step is that we fuse the blank cone beam CT with the previous CT angio of the patient. And then we have a Phillips room, so we use the Expert Guide, which is a live 3-dimensional needle guidance software system to puncture the endoleak, and this is what my beloved colleague, Dr. Rutger Lely, does. And I must say, it's always impressive to see this peri-graft flow, right? You almost think that is that you hit the endograft, but this, ladies and gentlemen, this is a type 2 endoleak, and when you connect a pressure line to it, you will usually see this type of systolic pressure around 80 millimeters of mercury. Next step is to do the sac angio, and it's always surprising or impressive to see that a small endoleak on the CT angio looks really like a massive leak on the SEC angio. And some endoleaks, they have 1 or 2 connected branches, but other niduses, or what is the nidus here? It looks like 4 niduses. They have multiple connected branches. This is the difficulty of treating these endoleaks in what way whatsoever. When we did the SAC angio, when we do it, we outline the SAC angio in AP and lateral, and then next step is that we fill the nidus with the polymer. And usually this takes about 5 minutes. During the filling, we check in AP and lateral that we are not filling outside of these lines. We had this before, and then it might damage the patient.
Quick question over here.
Yes.
With that drawing, are you trying to calculate the volume of polymer you will need, or is it just for your guidance to?
In our experience, it's impossible to measure on the CT scan the volume of the polymer that you need. So it's eyeballing, actually. It's really difficult to make a calculation of the polymer that you need. These are the preliminary results of the first 50 patients. 88% was male, 77-year-old. They had a diameter of almost 80 millimeters before the procedure. 20 patients already had undergone previous interventions like coiling, etc., glues. The time between the EVAR and the NFX procedure was almost 5 years, and the total procedure time, including anesthesia, etc., software, was more than 1.5 hours. But the injection time was only 6 minutes of the polymer, and we used around 24 mils of polymer on average. Sometimes you're wrong. This was a procedure that we did together with Professor Maleu in Leuven. On the CT scan, you think it's a type 2, but when you do the translumbar puncture right into the nidus and you do the SAC angiogram, you're surprised, oh, it's a type 1B endoleak. This happens. And we had type 1As, we had type 1Bs, I think we even had type 3 endoleaks. We didn't see it on the CT scan, we did the angio. So it's also a nice diagnostic tool. It's a different kind of endoleak, and we did not treat this patient with polymer. Technical success is high, thanks to our colleagues of interventional radiology. They almost always succeed in puncturing into the endoleak. We only had 1 dry tip. And we now have 6 months follow-up, which I agree is relatively short in 46 patients, and 85% had no further sac growth. Take care, we had 2 really serious complications. 1 patient in the first part of the study had spinal cord ischemia due to non-target embolization, and 1 patient had a rupture 2 days after the procedure due to excess filling. We filled outside the outlined nidus. So this resulted in protocol changes. The viscosity of the polymer was 3-fold increased. Now we do active blood pressure management to lower the sac pressure. When we measure it and it's more than 100 millimeters of mercury, we ask the anesthetist, please bring down the systemic blood pressure. And we have an adapted filling technique. So in conclusion, these first results show that this anafix polymer in patients with persistent sac growth is feasible and safe, relatively fast, clinically effective at 6 months, but mid and long-term results have to be awaited, of course. A new exciting field is prophylactic sac filling. Probably you heard of this. There are all kinds of materials. We now use this anafix polymer also in patients during an EVAR procedure. Hopefully the first results in 5 patients will be published soon. We now treated 10 patients, and this might be maybe better than treating endoleaks as preventing endoleaks.
Next year.
Yeah. I hope so. These are the collaborators of the study, and I would like to thank all contributors who worked on this study. Thank you.
Thank you so much. Very few times for some question or remark. Very impressive.
Are there any questions or comments?
Yes.
A very good presentation. I will elaborate a little bit more on the problems of type 2 endoleaks. One of the issues, I think, with the sac filling directly during the initial procedure, you definitely will not see endoleaks anymore because of all the radiopacity.
Yeah, good comment. It's absolutely true. The tantalum, the scatter prohibits that you see the endoleak coming. But what we see, the problem is solved.
We are waiting for the next edition. This is the first complication during the procedure or during the polymeric injection, especially if you have some disjunction and the polymer may enter into the endograft, or we can imagine a lot of complication possible.
Yeah.
Because you say that you have found some type 3 endoleak also, no?
Yeah. Yeah, this was the reason for treatment of the patient. We thought it was type 2. We did a sec angio, and it directly somewhere went into the endograft. Wow. So these CT scans are not the best diagnostic tools to definitely diagnose type 2 endoleak.
I've got one comment, but I know we're out of time. Do you think we should go? Can I ask one question, or shall I defer it? The question I have is, so with this polymer, does it cause a hypothermic reaction, or is it just a space-filling mechanism?
Yes, it's not causing a hypothermic reaction. My
concern with space-filling only is, in Onyx, for example, when we've used it in other instances, it fills the space, but sometimes, if there's continued aneurysm sac growth, or, is there a likelihood of flow around that rather than it necessarily sticking? But I guess your long-term data may show that.
Yeah, the surface is not thrombogenic. We have had many discussions with the company who produces the polymer that maybe you should add some thrombogenic material because the outside of the material is like soft. So this is a potential issue for the future. Yeah. We just have to wait the long-term results. Yeah.
Amazing. Thank you so much once again. Exciting time. So next is really a pleasure to introduce Dr. Vandenberg, who's going to talk us, carry on the theme of type 2 endoleaks. Thank you.
Thank you so much. And I think Arjen already did a great job of demonstrating how difficult it is to get this right. There are, of course, a lot of failures to be expected if you are trying to deal and treat patients with type 2 endoleaks. Of course, there are many more, but we're focused this time on type 2 endoleaks, IMA, lumbar, combined IMA and lumbar. And as Arjen already mentioned, it's oftentimes the case that there is a combined type 2 and type 1A or B endoleak that you don't perceive on the CT angiogram, or you have a suspicion on the CT, and that is, of course, asking for a completely different approach. But I will focus on the IMA and lumbar and the combined ones. And we have a lot of treatment options for type 2 endoleaks. Typically, we need to embolize the inflow and the outflow arteries with or without secombolization, and we have a lot of routes that we can take: transarterial, iliolumbar, IMA, deep circumflex iliac artery, translumbar, but also think about using a transcaval or perigraft approach, or even from the inside of the graft, puncturing the endograft from the inside and then getting into the aneurysm sac. And then we need to choose between coils and glue. But I think that one of the next speakers, Rutger Lely, will talk about the use of glue or liquid embolics. Then we need to choose the treatment modality, and this is driven mainly by the ease of access. You can go directly from A to B, that's translumbar. If you are focusing or wanting to do it with transarterial, you need to do a lot of work, a lot of catheter skills, and microcatheters are needed. But it also depends a little bit on what you have available. Do you have cone beam CT? Do you have fluoro CT? What are your navigational tools? What do you have catheter-wise and wire-wise? And of course, also it depends on your experience. The choice of pathway, we know that transarterial embolization has been reported to be more effective for IMA source than for lumbar source type 2 endoleaks. The translumbar route is more successful in obliterating the endoleak on follow-up imaging, and this is data from a meta-analysis. And one of the important things, translumbar is much faster because it requires a little bit less catheter manipulation. There are very different causes of failure, multiple feeders, simple versus complex endoleak. I think treatment of the nidus is essential, a little bit comparable to the treatment of intracranial AVMs. The visualization of the outflow vessel is predictive of transcatheter embolization failure. So if you don't address the outflow vessel, then you're going to see the patient back. And you need to take into account that treating type 2 endoleaks is very, very frustrating. Failure will occur. Some people claim 92% success rate, but I think in practice this actually is a little bit lower. And then there's one study that indicates that results with transcatheter and translumbar approach are comparable, but only if you use a very meticulous technique. And what is a meticulous technique? Here you can see a case where there is an inflow from the left side translumbar, but there's an outflow to the median sacral artery to the right as well, and then the nidus is embolized, so you need really to take care of everything, cross through the sac into the other side, and this can take a lot of time. Can we predict the outcomes based on the CT? If you are able on the CT to trace a potential catheter path from the IIA through the iliolumbar and lumbar arteries to the aneurysm sac, then you can manage to get there with a microcatheter. If you cannot trace this, then the patient should be considered for a percutaneous or a transcaval sac puncture. So the title of my talk was Good and Bad for Transarterial and Direct Puncture, and I will show you just some examples. This is a case that you can do either way. You can see this endoleak in the ventral part of the aneurysm. You can stick this, of course, from the back, getting into the nidus, and then do your coil or glue embolization. But in this case, I went through the more complex route through the SMA, arc of Rieland, and then all the way to the origin of the IMA, and then coiling the nidus itself, and then also the origin of the IMA itself.
Yes. When you're passing through the SMA down to the IMA, usually how long does it take? Median?
20 minutes.
Okay.
But we do a lot of microcatheter things, and I think that is really a driver for the choice. Plan this with the CT in mind, see where the takeoff of the origin of the arc of Rieland is, and then once you're in there, the most difficult part is oftentimes getting from the SMA into the side branch, because that is oftentimes a very perpendicular takeoff or even a reverse bend, and that, of course, if you come from the origin of the SMA and you need to go back 180 degrees, then you lose a lot of pushability. The moment that you are in the arch itself, it's getting really easy. What I do, because the guide wire always has the tendency to go into the side branches, what I do is try to create a loop, and you saw that also in this case. I try to create a loop in the guide wire, and then it's just pushing, and then it will follow the. I can go back probably here.
Are you using ProGrid?
Yeah, this is a ProGrid. And there are some other things that you need to keep in mind, but with the looped wire, the wire doesn't go into the side branches anymore, and then you just go very easily through the arch of Rieland. Okay. So that's a tip to make it go a little bit faster. Once you're inside, then everything is relatively easy.
Okay. Please go.
Always take care to use a relatively short diagnostic or support catheter, because you're going to lose a lot of length here. And then if you start with a 100 centimeter diagnostic catheter, then oftentimes the 50 centimeter that you have of your microcatheter additionally, and you need to subtract already around 10 centimeters for the hub or the Y connector that I always use to flush everything, to lubricate everything, and that really makes it easy.
Okay, please go on.
So this is relatively good. Also, this is a straightforward anatomy. You can see the trace being made on the CT angiogram from the internal iliac through the iliolumbar and to the lumbars, and then with image fusion you can see that it's relatively easy to get there. And also here you can see that I was using a looped wire technique in order to avoid entrance into the side branches. And then you can see on the right hand side the occlusion with coils of the outflow and the inflow in this case. These are the bad cases. So this is bad for transarterial, good for direct puncture, failure to reach the origin of the lumbar artery. This really looks like one of the cases that you showed. You see this reticulum on both sides of the aorta, and this is almost impossible to embolize transarterial. I've seen Japanese colleagues working with triaxial systems, even coming from intercostals to get into everything. But I think that's way too cumbersome. So in this case, you go for a direct puncture. This was done initially with CT guidance. Then the patient was put on the stretcher and put into the angio suite. And then unexpectedly, in this case, we didn't see an IMA source of the endoleak. Then the additional feeder showed up, and this was, of course, the IMA. And here you need to be a little bit careful with your glue to inject. Also, this is an example, good for direct puncture. You can see a nice entrance possible from the back. Bed for transarterial. You can see all the reticulum. And also this was treated with a direct puncture without any problems. And this is another technique that you can use. This is CT fluoroscopy guided injection of onyx. Also here a similar case with a big reticular feeding of the type 2 endoleak. And then on the right hand side you can see direct puncture with a needle, injection of onyx in this case, and that solved the problem. So, if you treat type 2 endoleaks, meticulous technique is mandatory. I think if you see a single feeder IMA and lumbar endoleaks with a traceable pathway, those are good candidates for a transarterial approach. All others, I think, are best treated with a direct puncture. And with that, I thank you for your attention.
Thank you so much. Great sort of overview and really pragmatic tips on managing endoleaks. Are there any questions or comments from the audience?
I've got one comment. When you start the talks, you mentioned 92% of success for type 2 endoleak treatments. This is not my practice. Maybe I'm very, very bad at
These are not my results.
Okay, thanks.
And this is a figure that I took from the literature, but I think it's over.
Lower.
Yeah.
It's lower. Yeah, that's technical success, but the clinical success is.
Yeah. I think you see probably.
This is the initial technical success, not the success in follow-up.
40% recurrence rates.
I'm intrigued by the. What was shown earlier on about how pressurized these sacs are. When you do direct access, do you measure the pressure in the sac?
Typically I do, and I see similar values from 60 to 90 millimeters of mercury. Yeah. It's a relatively flat curve, so you don't have the systolic peak, but it's a little bit dampened, which makes sense. Yeah. And that's probably also the reason why. When type 2 endoleaks rupture, the patient don't bleed to death instantly. You have much more time, but they do. Yeah. One of the other issues with glue injection is, or with in any case with treatment of type 2 endoleaks, it's also one of the reasons why they recur is because new pathways are opening up. This is something that is also known from vascular surgery, from open surgery. If you don't suture all the origins of the lumbar arteries, there might be some recruitment, and that's probably a kind of ischemia that is trying to get.
We have a good question over here.
I hope so. Jos, thank you very much as always. We do far more sacograms than we think, because we always do an angio before we put in a contralateral limb. And the point I want to make is that we see so many big lumbars being open when we do these in sacograms for a completely different reason. And you have the same when you treat endoleaks. Yeah. You go to the sac, you do an angiogram, and suddenly you say, oh my God, I saw 2 lumbars on the CT, now I see 6 or 7. So the one conclusion must be that on the CT scan we cannot appreciate the value of the endoleaks. Yeah. So my question to you is, would you advise to do a good angio all the time before attempting the treatment? And with that in our head, is it ever going to be really effective, what we do?
Yeah, I think that's a very good point, Eric. I think that is pretty much the reason why we fail so often with the treatment. And I make my selection nowadays more on the let's say the ease of access transarterial. If I think it's doable, then I will do it. But then oftentimes you still have surprises, and then you see all this reticulum that is feeling, and then you just need to say, well, stop. What you shouldn't do in those cases is just think, well, I got somewhere close, and then you are embolizing some branches 10 centimeters of the aneurysm sac wall, and that doesn't make any sense.
I think we need to move to the next speaker, Craig.
Thank you so much. Once again, thank you so much. And so continuing the Dutch theme for the last part of the session, it's a pleasure to introduce Dr. Rutger Lely to continue the conversation about type 2 endoleaks. Thank you so much.
Yeah, thank you for the invitation. And is Jos still here? Yeah. And at the PVI you want discussion, but unfortunately for you, I totally agree with Jos with the approach on the type 2 endoleaks. These are my disclosures. Now this has already been said. There are a lot of papers on how to attack type 2 endoleaks, different approaches, but also different materials, embolic materials, coils, glue, other liquid embolics like onyx. And there's all the papers are in a retrospective fashion. So the first case, well, type 2 endoleak, of course. Here's a type 2 endoleak, and I almost always try to do a translumbar approach nowadays, but I'm going to show you two cases in which I did a transarterial, and I'm going to say why, because it's discussion. So you see here the sort of Elmo. I don't know if you know Elmo from the Muppet Show, but it looks like this. It's his nose that is the endoleak, and she had some orthopedic surgery before. And normally the transarterial embolization, the outcomes are very, very poor. This is a paper which is said they looked at all the transarterial embolizations, and after 5 years, I think it's only 17%, and all the others dilated. So what I do is I use the vessel nav. You can see here, I hope the pointer is, oh yeah, you showed me yesterday, Eric, how to use it. This is the after kidney implantation, so transplant. And here you can see I use the VES nav, and I go by the ipsilateral route, take the internal iliac, the iliolumbar artery. The pointer is very hard to handle, I have to say, but I'm trying, and get in the aneurysm sac. And I, again, totally agree with Jos. You should treat the nidus. So we get here in with the prograde, as you can see here. So we're in the nidus at this point, and then try to cross it and try to get to the other feeding vessels, of course. And this is, of course, if there are many lumbar arteries, then it's very, very difficult. But I look at the pre-procedural CT, and if I see like a big nidus with two big lumbar arteries, then I choose, in some selected cases, I use the transarterial approach. So here you can see, we get to the other side, like here, we put in a coil, and then on the way back, normally I try to do first a coil in the proximal artery, and then go back in. As you can see here, so first I do the coiling, there it is, and then go back in, and then I treat, in this case with the onyx, and try to close all the nidus, and also get in, as you can see here, beautifully, into the lumbar arteries. But like after 6 months, we treated the aneurysm, and as Jos already mentioned, there's no growth, but you can see still there is some type 2 endoleaks. Small spots, but I think your clinical success will be no growth. Yeah. So, but we have to wait like for 2 years, and even after 5 years, it still can grow. So, the second case is a male. He has a type 2 endoleak, but this endoleak, it grows. The native aortic sac is growing, but this looks really like like Eric says, a brutal endoleak, and you're not really sure if it's only a type 2, right? Because it's so around the endoprothesis that you might think, can it be like a type 3? So you do is like the procedure is also the evaluation of the type of endoleak. Yeah.
Just about, you think that's the speediness of growing of the sac could induce that this is a type 2 or that could be a type 3, especially when we don't see exactly where it's coming from. I guess that could be a good indication. Either a very fast growing, for me this is no more a type 2, that becomes, of course this is a type 1 A or B, it's always visible, or almost always visible, but that could be a type 3 that we can see.
I totally agree, and that's why this person had a very large IMA, right? But I found the endoleak so, well, we all did, and the MDT, it's so weird looking for the type 2 endoleak that we thought, well, okay, let's do the procedure, see how the endoleak looks like, and then we can do the treatment at the same time, right? So, in the angio suite, and so we did the mesenteric approach, let's say it like that. So again, the vessel navigation, which outlines the way to the IMA, as you can see here. And in a lot of cases now, I use the steerable sheet. And I do that for different reasons. First of all, you have like a very good angio, right? Because you can do a lot of contrast inside of it. Then, as Jos already mentioned, the way to the IMA goes off sometimes in a 180 or even more degrees. So then I put in a 100 centimeter Berenstein for French catheter, and then through that I use the prograde. So we got inside, got in the nidus, and we closed off with a coil. Again, I coil the IMA first, go back in. Then in this case, because it's a very big endoleak, I do coils and I do liquid embolics. In this case, onyx again. But also here, it looks great. Well, as I showed you this picture, because now it looks, there's no endoleak, but if you look very carefully, you can see contrast. And if you go above and you use IMAR, so for the scatter reduction CT series, you can see the endoleak again. So this is really short after the procedure. There's no growth, but we have to see what happens in the future. So are liquid embolics the answer? I still don't think they are the holy grail. They're definitely an adjuvant, and you can combine them with other embolics. But I have to say, persistent type 2 endoleaks are really hard to treat. I want to thank you for your attention.
Thank you so much.
Questions?
Yeah.
Great, thank you for your talk. Just curious from yourself and also the other speakers, just in terms of when we're looking for the endoleaks and their cause, where does the role of diagnostic angiogram fit into your algorithms?
Well, as I showed you the last case, I think sometimes you can use the angiogram in our hospital. Sometimes it's really hard to define if it's a type 2 endoleak or type 3 or whatever. So first of all, of course, we do normal CT like Blanco and arterial and portovenous. Then we use the CT, dynamic CT, and even now we're thinking of using MRI as well, because there are some great papers about that you can see the endoleak better, and you can also use that in a dynamic fashion.
Rutger, may I disagree and go back to the question that was posed before, because I think the value of a very good angiogram is that you can determine your treatment afterwards, including the semi-conversion, where the surgeon wants to be very sure that there is no type 1A for sure, but also no type 1B endoleak. So I think we should approach this a little bit more carefully and don't be afraid to split the diagnostic angio and the treatment angio. That's what we try to do, to play it as safe as possible. And as you said, a number of interventions will fail, and then you don't win anything. So I think the differential treatment is very important.
I want to curve the enthusiasm, or I want to say this is an hybrid decision. This is what you mentioned, a very good angio, plus to review, if it's necessary, the angio CT scan, especially in the most complex procedures, all the branches, all the bridging stent connection, type 2, type 1A. This is always, and most of the time, very difficult.
I agree.
And I agree what you say. No decision to get back to review all the exam and to change your decision if it's necessary.
I totally agree. I think, but in that last case, so we made an angio, and you don't see a type 1A, type 1B, because it was such a strange endoleak, but you know this, and if that's then in the end is a type 2, which
fortunately.
Yeah, and then you treat at the same moment. Yeah.
Brilliant. Okay, we go. Last one, Tadas.
Yep.
Please.
Let's go. Let me introduce you. Well, he doesn't need introduction.
And he has the supportive team. Yeah. He don't need, because he's an expert.
Yeah, Dr. Athanasios Katsagoris from Nuremberg. Because after all of this discussion, liquid agents, coils, and translumbar, transarterial, now the solution is to convert.
This is just for destroying the enthusiasm.
Thank you very much for the invitation. It has been a very nice meeting. And I do feel a little bit alone, however, in this session with coils and gluing and all these sophisticated techniques, but I will try my best. So these are my disclosures. And if we look at the latest ESVS AAA guidelines, it is suggested indeed that we should try first to treat type 2 endoleaks primarily by endovascular means. And then there is a new recommendation in these guidelines that if we do so and we do one or multiple attempts, then we can consider open conversion to treat these endoleaks. And the question, of course, here we have been talking many times today, is how really effective are these endovascular attempts to treat these type 2 endoleaks. This is just an example from our latest experience. Type 2 endoleak, it seems relatively benign from the IMA, a large aneurysm, so we decided to do an embolization. This is a successful, so to say, technical embolization. We don't see any endoleak anymore, but here we are again 6 months later. We have a persistent endoleak. The aneurysm is still growing. It's now more than 10 centimeters. And now what? I guess we all have been there trying these endovascular techniques, and then we keep having a growing aneurysm, and then we have to make a decision what to do with these patients. So if we look at the literature, there are some data out there. This is a nice review and systematic review and meta-analysis showing that indeed, in more than 1,000 patients, all these techniques had a clinical success below 70%. And if we look at this multi-center Japanese study, we see here a disappointing, in my eyes, freedom from sac expansion. So after embolization procedures, only 37% of the patients had freedom from sac expansion during follow-up. And based on this, quite logically, in my eyes, the authors concluded that these techniques and procedures have only limited effectiveness in controlling aneurysm sac enlargements during follow-up. Now, we need, of course, to understand and to realize that not all type 2 endoleaks are the same. If we look at the endoleak on the left image, we have a nicely defined endoleak, probably from one target vessel, but if we look at the endoleak on the right side, on the right image, we have a diffuse, foggy pattern of endoleak, and this brings us the so-called moya-moya endoleak problem. This is the so-called ill-defined endoleak. We see in the late phase, not in the arterial, but in the venous phase, this diffuse, foggy contrast. We cannot really identify the vessels that are creating this endoleak. And this endoleak has been speculated to be related and associated with multiple sac-feeding vessels, including the vasa vasorum. This is one case from our experience. We had this aneurysm keep growing. In the arterial phase, everything fine, but in the late venous phase, we get this image as well. So at some point, we decided to open the sac, and as you see here, we find this vasa vasorum, these vessels in the sac, and this is just one of the 10 I had to try to deal with them until I got somehow, and after cauterizing the whole sac, and using even glue, we got to get the sac without bleeding anymore. And thereafter, we had to close the sac around the graft. So this is very important to realize that if we see this pattern of endoleak, the moya-moya type 2, we have a significantly worse prognosis, and it is not expected to treat this endoleak by endovascular means. And the reason is obvious. It is very difficult, for me almost impossible, in my hands at least, to try to embolize all this entire endoleak network in order to get rid of this endoleak. And it's not only this moya-moya endoleak, but I guess many of us would agree that we have an endoleak from the IMA and then other 3 lumbar arteries, at least 3 we can see, maybe it's even more. How really optimistic are that we can treat these endoleaks by endovascular means? And not only that, but some of these embolization procedures come also with complications. This is an example, type 2 endoleak from IMA, simple, quick coiling, but a few months later, the patients come back with an autoenteric fistula and opening the sac and the gut. We did found the coils having migrated in the small bowel. And we heard before about direct sac puncture, which may be a nice technique, but there are increasing reports, and we have also personal experience with graft infections after trying to do these procedures to get rid of these endoleaks. So, in my eyes, trying to treat type 2 endoleaks many times looks like this. On the left image, we try it again and again, and we never get a perfect result, and it's never going to be perfect. And on top of that, we spend also a significant amount of money in these multiple interventions without an optimal results quite often. So I think we should to think more liberal sometimes to beyond endovascular solutions, to open sac revision or conversion. There are many terminologies about that, because this way we can open the sac, we can have a direct endoleak identification and repair on the same setting, and most importantly, this procedure, most of the times, there is no need for clamping. Here we see an example. As you see, we have a large aneurysm. We open the sac without any clamp, proximally and distally. We can take the thrombus out, and then we have time to explore the sac quietly, take all these materials out, find the endoleak cause, and then after we control the endoleak, we can apply a tight sac closure around the graft and finish the procedure. If we look at the literature, and this is the Pittsburgh experience, for example, we see that if we can preserve the graft, and this is important in my opinion, then you reduce the 30-day mortality to an acceptable level of 3.6%. And the procedure appears also to be durable in the midterm. In this particular example, less than 3% of the patients required air intervention during follow-up. Having said that, if we look at this meta-analysis with almost 200 patients, we see first important point that indeed aortic clamping can be avoided in the great majority of the cases, but this technique has also limitations, and there can be a semi-conversion failure. In this meta-analysis, about 5.5%, with a reintervention rate of about 7%. And this is very important to realize, because looking also in our experience and some other published data, I think it is very important how you do this semi-conversion. It's important to have an aggressive dissection of the sac in order to be able to apply really a tight plication around the graft, because this seems to reduce the risk for sac re-expansion over follow-up. And before I close, I think this is very important. We try to touch it a little bit before. Before you plan to do a semi-conversion, look carefully your proximal and distal sealing zones and make sure that there is no type 1A endoleak. And if needed, don't hesitate even to extend your proximal and distal sealing zone to make sure that when you open the sac, it will be just a type 1 endoleak or maybe a type 3, but a type 2 endoleak, but not a type 1 endoleak. This is, to my opinion, a very important message before you start doing this procedure. So, to put all this together, I think we can say that embolization of this type 2 endoleaks is commonly not effective, especially if we are dealing with these moya foggy diffuse endoleaks. And to my opinion, if we put the indication to do something for the type 2 endoleak, because it's not always that we have to do something, but if we decide to do something, we may have to be more liberal and go for open conversion. There is no need for clamping if it is a semi-conversion, lower mortality and morbidity compared to complete conversion, and it is effective in the majority of the cases in the mid-term. Thank you.
Thank you so much, Hans. This is your glass if you.
Sorry?
This is a glass of water if you want.
Ah, yes, thank you.
I 100% agree, and thank you for having said that. The proximal security, and this is what we do usually, especially on the very frail patients who do not want to convert totally. We first had in previous EVAR a fever to be sure that will be proximally very sealed and very secured.
Absolutely.
And if it's necessary after this, we convert, but this is almost a semi-conversion. And it works very well with no clampage necessary. And what we have seen in some cases, can't exactly remind me the percentage, but what we thought that was a type 2 endoleak, finally that was a type 3 with a very millimetric tear in the graft that was bleeding, that's impossible to see, and we suture directly. That remains a huge problem.
And that's an important point you're mentioning, because sometimes if we're not sure that it's a type 2 endoleak, we may have to consider also relining of the graft before opening the sac.
Yeah.
This may solve the problem in some cases.
That's why it's type 2 and 3. Yeah, please.
Yeah, can I ask a question? I'm not a surgeon, so maybe this is a very stupid question, but you showed this great case, right? Over the open conversion without clamping, you open up the aneurysm sac, then you tightly close it. Don't you ligate all the lumbars and the IMA? Because is it possible, if you don't, I don't know if you did, that you get a type 2 endoleak again and then it will grow? Is it?
Well, obviously, if we have a back bleeding, we do so. But if there are already thromboses and we don't see anything, and that's why I said we take all thrombus out, even the endothelium sometimes, and we try to have a very clean field of view in order to see if there is back bleeding. And we just go and suture what is giving back bleeding. But the message for this case was that although there was no official large vessel giving back bleeding, there was all these tiny collateral vessels that they were still filling the sac the whole time.
Manny?
Thank you. A very, very nice talk, and you're not alone in the room, I guess. Yeah. I have two maybe comments and one question to you. Number one, you showed nicely the vasa vasorum. I think that inflammation has a big impact also. So we see a diffuse bleeding sometimes of these walls. And the second thing is the reinforcement that you showed. I think there's a technique shown, it was in my former hospital in Heidelberg, shown by Allenberg, that a reinforcement can also be performed with the outside cuffs.
With bonding, you
Yeah, with bonding and that stuff. Yeah.
Yeah.
So just to complete that, but my question is, at what time would you switch? What is your threshold to say we not go further investigating or coiling or whatever because we want to save the money? You showed the bucket with the money. We want to save the money. We switch directly to that. Is there a way to say that?
That's a very good question. I wish I had a guideline to share, but I tend slowly to say that if I have only an IMA isolated endoleak, I may go for an endovascular attempt to coil embolize it. If I see this moya endoleak, I don't try it at all, and I say either I wait or I do the semi-conversion. And if I see multiple lumbar endoleaks and IMA and this and that, then I just stop and I say either it's a fit patient to undergo an open semi-conversion with very good proximal and distal ciliary zone, or I don't do anything. You can't even say that because we have now the new paper from the US with the Medicare data showing that even if we do all these interventions, there is no real significant advantage in survival for type 2 endoleak. So we have also to keep that in mind.
And there is also one thing that you mentioned, this is the fact that with multiple intervention, I mean endo intervention, there is always the risk of infection, at least of the endograft.
That's very important. We have bad experience, I must say, with translumbar. We had a few infections, and then you have a simple problem, potentially dangerous, but maybe not, and you convert it in a really trouble.
Last question.
Last patient that I treated this way, or tried to treat this way, was a patient when I opened up the sac. He had a type 2, but also type 1 and also type 3. So I was really lucky that I had prepared a clamp position. My question to you is, do you, when you are convinced it's a type 2, do you still always make a clamp position?
Yes. In standard EVAs, absolutely. It might be some cases where we have already fenestrated EVAs and they go very high. In these cases, we put a balloon. And actually, I put the balloon from the axillary axis. So if I need to take everything out, I have not the balloon in the middle of my way.
And in the case you're wrong and it's a type 1A, do you remove the graft if possible, or do you sew the sac wall onto the graft for 3/4 of the surroundings? That's what I do when the leak is on the front side, when the patient is frail.
Previous figure.
Yeah, for example.
So of course this is very individual and it's on the point on the table. If I feel that I can somehow repair it, I try that. But if I see really a type 1 endoleak, then I take the graft out, not the whole graft. Maybe I leave the suprarenal part there, but I do a almost complete conversion. So
but because we saw the mortality rate is quite high for these operations.
Yes.
It's higher than a standard AAA operation.
Of course, absolutely.
Who wants to conclude?
You close, please.
No,
you are the master.
Come on. I started, you close.
Okay, thank you very much. I think this was a great session, great discussion. Thank you for your question. Thank you to all the speakers. Great talks, great discussion.